Hello, everyone, and welcome to EMS, a critical link to emergency stroke care. This is part of the TeleSpecialists Lunch and Learn series. Today, we will be joined by Dr. Vahid Behravan and Dr. Theresa Sevilis. Dr. Behravan has been with TeleSpecialists since 2018 and has since taken on the role of Director of Clinical Research. He graduated from medical school in Iran with a neurology residency at Kansas University and a fellowship in neurorehabilitation. He is board certified in neurology. In his free time, Dr. Behravan enjoys painting, calligraphy, photography, music, weight training, and lives in Maryland with his family. Dr. Theresa Sevilis is also board certified in both neurology and vascular neurology. She completed her neurology residency at Kaiser Permanente, Southern California, and her vascular neurology fellowship at UNC Chapel Hill. She attended Midwestern University for medical school, and Dr. Sevilis joined TeleSpecialists as a teleneurologist in 2017 and has since become a regional medical director in January 2019. Dr. Sevilis currently lives in North Carolina with her husband and 2 children. In her free time, she enjoys exploring nature with her children, yoga, baking, and traveling.
Hello, I'm Dr. Vahid Behravan. I'm a neurologist with TeleSpecialists, and I've been with the company for about 2 years. I'm very glad to be here today with EJ Andrews and Dr. Theresa Sevilis presenting today's webinar, EMS, a critical link to emergency stroke care. I have no relevant disclaimers. So what's a stroke? Stroke happens when blood supply to part of the brain is suddenly interrupted, and it has 2 major forms. One is ischemic. Majority of the strokes are ischemic. About 87% of the strokes are ischemic strokes, and it's caused by a blockage in the artery that stops the normal blood flow and oxygen flow to the brain, causing potential damage and symptoms. And there are 2 major types of ischemic strokes. So sometimes a clot forms in more proximal arteries or in the heart and then kind of breaks off, goes to more distal arteries and causes a stroke. And other type is the blood clot forms in that artery that provides blood to the brain and causes ischemic stroke. Then hemorrhagic strokes are less common. About 13% of strokes are caused by hemorrhage, and it's basically a breakage in the blood vessel within the brain that can be from trauma or ruptured aneurysm or arteriovenous malformations. And there are 2 major types of hemorrhagic stroke. Intraparenchymal, or sometimes it's called intracerebral, when the blood vessel bursts and blood leaks to the tissue of the brain. And subarachnoid hemorrhage, when the blood vessel bursts near the surface of the brain and then blood pours everywhere around and outside of the brain, between the brain and skull. Now, some stroke facts, most of them are taken from CDC. Some of the numbers may have changed more recently, but still pretty close to what we see now. Stroke is pretty common ailment. It affects someone in the United States every 40 seconds, and unfortunately every 4 minutes someone dies from stroke. Every year, more than 795,000 people in the United States have stroke, and about 610,000 of them is the first time or new stroke. About 185,000 strokes, almost 25%, are people who've had strokes in the past. So this is their second or more stroke. And stroke kills about 140,000 Americans every year. 142,000 new numbers. And it's about 1 in 19, 1 in every 20 deaths, and it's the 5th leading cause of death in America. And even though strokes can happen in any race and ethnicity, but risk of having a first stroke is nearly twice as high in blacks as for whites, and blacks have a highest rate of death due to stroke. And even though the rate of stroke deaths have declined for decades among all races and ethnicities, Hispanics have been seeing an increase in death rates since 2013. Stroke can be seen at any age. Even teenagers can have a stroke. The risk of stroke increases with age, but again, it can happen at any age. And in fact, in 2009, 34% of people hospitalized for stroke were younger than 65 years old. Stroke is a leading cause of serious long-term adult disability. About 4 million Americans are living with effects of stroke. Now, with people who have a stroke, 50 to 70% of them, of the survivors, regain functional independence. Now, that doesn't mean they're completely back to normal, but they do regain their functional independence. Unfortunately, 15 to 30% of these stroke survivors are permanently disabled, and a stroke reduces mobility in more than half of stroke survivors 65 years old and over. National Stroke Association estimates stroke costs the U.S. about $43 billion a year, and direct cost to the medical care and therapy averages about $28 billion a year. Average cost per patient for the first 3 months after a stroke is $15,000, and 10% of these cases could be even more than $35,000. So, what are the risk factors? So, just like anything else, preventing a condition, a disease, would be better than treating it. Same with stroke. Preventing stroke would be preferable. So, we have to know the risk factors. Now, the risk factors, we kind of divide them into two major groups: risk factors that we can control, the modifiable risk factors, and then risk factors that we cannot control. So, the most important risk factors that we can control: high blood pressure is the most it's the number one controllable risk factor for ischemic stroke. Smoking, especially, if someone is on oral contraceptives, the risk is even higher. Diabetes, high blood cholesterol. These four conditions are present in many patients who present with ischemic strokes. Diet, so it's better to have less fat, less salt, and more fruits and vegetables in the diet. Physical inactivity, the problem of modern era. The goal is to being active at least 150 minutes a week. Obesity, carotid artery disease, peripheral artery disease, atrial fibrillation, which is a very important condition. It increases risk of stroke by 5-fold. Other heart conditions: coronary artery disease, heart failure, cardiac dilated cardiomyopathy, valvular disease, sickle cell disease, and some minor risk factors such as geographical location, socioeconomic factors, alcohol abuse, drug abuse, and sleep habits. So these are all modifiable and we can control them. There are risk factors that we cannot control, unfortunately. Age, family history, race, gender, prior stroke, TIA, or heart attacks are the risk factors that we cannot control at this point. Now, how to recognize a stroke? What's interesting is that, at least in one survey, most of the respondents, over 90%, knew that a sudden onset numbness on one side of the body could be a symptom of a stroke, but only 38% knew all the major symptoms and knew when to call 911. And we know that the sooner the treatment is started, the better outcome we will have. So if the patients are in the hospital, in the ER sooner, they will have less disability later on. And even in paramedics, if they didn't have any training, their sensitivity to pick up these symptoms was about 61, 66%. But then after training was even close to 100% sensitivity in detecting stroke symptoms. There are multiple scales and ways of screening stroke symptoms prior to getting to the hospital, so pre-hospitalization. Cincinnati pre-hospital stroke scale that we're gonna go over shortly is one of the very popular ones, a common one. Los Angeles pre-hospital stroke scale, and Miami emergency neurological deficit scale. These are just a few of several available scales that are approved and used depending on which one is approved for any region. Now, there's a consumer one, FAST and BFAST, that again we're going to go over, which is kind of derived from Cincinnati, and you'll see that they're very, very similar. It's more for the consumer, but it assesses the same deficits. Next slide. So Cincinnati pre-hospital stroke scale, you see that there's facial droop. So if there's no facial droop, it's normal. If there's facial droop on one side, it's considered abnormal for that element. There's arm drift, so arms both palms up in front of the patient. If there is pronation, turns a little bit, or if there is a drift in especially one side, then that would be abnormal. But if the patient can't hold them up, palms up, then it would be considered normal. They have to hold it up for 10 seconds. And then abnormal speech, you just tell the patient to repeat a pretty familiar saying like, you can't teach an old dog new tricks. If they can do it correctly with no slurring, no substituting or forgetting words, then it's normal. And then if you see, any slurring, wrong words, or unable to say it, it would be abnormal. So if they have one of these signs, then the probability of a stroke is 72%. So it's a pretty good pre-hospital scale. Next slide. Another example is Los Angeles pre-hospital stroke scale. So what you see is that, there's more elements for EMS to document, which doesn't necessarily make this, the most popular scale. And also what it evaluates is just limited to face, grip, and arm weakness, which, obviously can miss some of the other potentially main symptoms from a stroke. But it is validated and it is used in certain regions. Next slide. Now, FAST and BFAST, again, this is derived from Cincinnati, and it is for the consumer. So originally it was FAST, meaning face. So if the face was abnormal, a droop on one side, arms, if there was a drift or weakness on either of the arms, speech, if there was slurred speech, any abnormality in speech, and then time. It's time to call 911, time to get the patient to the hospital, because as every second passes, brain cells die. Then later on, B, balance, and E, eyes were added. So if there was any loss of coordination or balance, and if the patient was having trouble walking, or if there was any blurred vision, double vision, trouble seeing, field cuts, then those would also be symptoms that were important to call 911 and know as potential symptoms of a stroke. Next slide. So there's 7D or 8Ds of stroke care, and Dr. Sevilis after me will go through in much more detail for many of them. Just very quickly, my time is almost up. So detection, again, detecting the symptoms in the field, in the community, and then dispatch, knowing when to call 911, and then the dispatch knowing that these are appropriate signs of a stroke, and informing 911. EMS arriving, doing their appropriate care that we discussed Cincinnati, and there are some other scales, and we can go through them over Q&A, and then delivery to the hospital. And establishing some very, very important data that, again, Dr. Sevilis is going to go over. Getting to the hospital, evaluation in the ER, and then data gathering. The data in the ER includes CT examinations, non-contrast CT exam of the head, which is crucial to our initial evaluation. Then the decision-making, medications, procedures, and then whether we need to have any additional advanced imaging, such as CT angiogram. Then drug and device, whether a patient is going to be a candidate for thrombolysis with IV TPA, and whether they're going to be a candidate for endovascular therapy, thrombectomy, and then eventually disposition. And that's just the continuing of care, and where the patient will have the continued care after the immediate evaluation and treatment. I just want to thank you guys. The stroke care would not be possible without EMS, so we are really reliant and dependent on you guys for providing good quality stroke care to our patient. I'll pass to Dr. Sevilis for the rest of the webinar.
Hey, hi everyone. So I'm Dr. Theresa Sevilis, and now that we know more about stroke, let's start talking about what we can do to help treat it. Next slide. So time is brain, and that's really what we're talking about here and why EMS are just so critical in how we're able to care for our stroke patients. 1.9 million neurons a minute are lost during a stroke. So really every minute counts, and what you guys are doing in the field to get these patients to us is brain saving, is really what it is. So if we can, next slide. So we're going to talk about acute stroke treatment. Kind of an overview of what we're going to go through here is the rapid identification of stroke symptoms, the EMS evaluation and transport, what we actually are doing in the emergency room, the different types of treatments that we have for acute stroke, the care they get in the hospital after that acute period, as well as touch a little on rehabilitation. So let's get started with the rapid identification of stroke symptoms. So the most important thing that we need to think about is identifying strokes. We just went through a bunch of scales and different ways that people can identify them, both in the field and for EMS to identify. But one thing that we know is that EMS involvement really changes our ability to treat patients and increases the odds of patients getting treated. The DASH2 study actually showed that when EMS were called and used for stroke patient care, that pre-hospital delay time was 2.85 hours as compared to 4.03 hours. And just to define what they mean by pre-hospital delay, it means the time from when the patient started having their symptoms to when they were able to get to the hospital for care. It's not implying there actually was a delay. And looking at the amount of stroke patients who use EMS, there's varying data, different studies. This one particular study I'm citing here said about 50%, and sometimes it goes up to as high as 60% of stroke patients, depending on the region, are actually utilizing EMS. Of ischemic stroke patients, there's about 54, some are a little bit higher, percent that are brought in by EMS. But what's interesting here is we do see the hemorrhagic strokes, a higher proportion, 72% of them are brought in by EMS, and TIA is only about 36% come in via EMS. Next slide. So we're going to move on to the EMS evaluation and transport now. So there's a few components that we think about when you think about the role of EMS. First is the same thing they would do when they're seeing any patient, making sure they stabilize the patient. Stroke patients can have altered mental status to the point of losing their airway and need to be intubated. There's lots of other things that can potentially need to be managed in that acute state that they need to address first, while simultaneously identifying stroke symptoms. So there is a lot going on and a lot of high pressure situations when you're responding to an acute stroke. The second part of that is once you identify that there is a concern for stroke here, then obtaining the pertinent history from family or whoever happens to be present, both about the timing of what happened and if it's family, any medical history that you can get, and then transporting them to the nearest stroke center and pre-alerting that hospital if that's ideally a process that's in place so the stroke team can be ready to go. And then when you arrive, relaying all the pertinent history to the stroke team so that they can start the care as quickly as possible. Next slide. And just touching on this again, we're not going to go into detail here, but there's many tools that can be used to identify stroke symptoms. We just got a great, nice overview of them, but it never hurts to show them to you again. Personally, I really like the BFAST because it involves that balance in eye and the posterior circulation, which are the most commonly missed strokes. Next slide. So now we get to the pertinent history. One of the most important things that can be gathered for us in the field is what we call the last known normal. And I know this is a term that's kind of very specific to stroke care. Most people want to know when something started, how long it's been going on, that type of thing. But for our care, we really care about when that person was last normal. And what that means is, so say you're sitting with your family member and you're talking and having a conversation and all of a sudden they stop talking. Well, okay, now you had a witnessed onset and that's their onset time, but it's also their last known normal because you talked to them right before. Whereas if you are in a different room and your loved one is downstairs and you come down and find them on the floor, weak on one side, well, when was the last time you saw them before you came downstairs? That's the time that actually matters for us to meet them. So if that was an hour ago, now that is your last normal, not the time that you found that patient on the ground. So that's a really important distinction to make, and one that I think is commonly misunderstood. And the other things that we need to know are vital signs, the blood glucose, getting any pertinent medical history, such as if they've had a stroke in the last few months, if they've had a recent heart attack, surgeries, if they had any recent trauma or trauma with this event, or any history of bleeding issues. There's always long medication lists for a lot of our patients, but the one that we really care about in the ability to treat patients is anticoagulants. So that's warfarin, Eliquis, Xarelto, Pradaxa, and the last time they were taken. Some patients can be on Lovenox too, not as common, but that would be another one that would be relevant as well. And then especially nowadays, with limitations of family members coming to the hospital, it's really important to get contact numbers. Having the number for either the next of kin family member, if that's something you can get from them, or whoever is present at the time, even if it is a coworker or somebody else, getting that information is really important if we need to clarify something in the story. Next slide. So next, we're going to move on to the emergency room evaluation component. Next slide. Okay. So once the patient arrives and you've given us all your history and examined information, the things that we need to know and that we'll either be gathering or getting from you would be the last known normal, what the symptoms are, if they're using an anticoagulant, if they've had any recent surgeries, any history of bleeding issues, any other medical history. There's a lot of other things that do play a role if they are on hospice from a cancer, or if they have a history of a brain tumor. Those are things that we're going to need to try to figure out too, but we don't put all of that on the EMS to get all the history for us. We understand that there's some aspects that we may need to find in the chart or from the family once they've arrived. And then another key thing that can be very helpful if you're able to get in the field is their baseline functioning. Is this person coming from a nursing home? Do they walk normally? Do they talk normally? Because we need to know how significant the change is and how much it would affect their quality of life. And the exam we do in the hospital is called the NIH stroke scale. And you can see that on the right here. And it's much more detailed than any of the screening tools, but this is a way of tracking and kind of grading how severe a stroke is. Next slide. And on every stroke patient, after we get that history and all those quick things, I'm sure you always notice us whisking them right off to CT. So the reason we have to get that CT scan is to see both if they have bleed or stroke already present. So you can see in the right lower slide, that the part of the slide there, the picture there is just a plain CT scan. That dark area on the left side is a completed stroke. So that would be what a stroke looks like. And then the other imaging we now get is CT angiograms, which you can see a picture of in the top right corner. If you look on the right side of this picture, which is actually the left side of the patient's body, you can see there's that white line that just abruptly ends, where on the left side of the picture, it just goes right through. And that's what we would see as a cutoff or an occlusion in one of those blood vessels. And even more recently, we've started using CT perfusion scans to help with some decision making. And that's what you see on the lower left portion of the screen. The simplest way to explain a perfusion scan is we're looking at parts of the brain that are getting good blood flow versus the areas that are getting deprived of blood. The green part in those pictures shows you the area of the brain that you can potentially save. And the pink, purpley color is parts of the brain that are already dead and you can't save. So that can help with certain decision making. Next slide. Okay, so now we'll move on to the acute stroke treatments we have to offer. Next slide. So there's two main treatments for ischemic strokes. One is IV Alteplase or TPA, and the second is mechanical thrombectomy. This picture here is showing you a large vessel blood clot, as we call it, but it also shows you some of the smaller blood vessels coming off of there. For the IV Alteplase, you can use that for a large blood vessel blockage as well as those smaller blood vessels, whereas the mechanical thrombectomy is only for the larger blood vessels. Next slide. So we'll start by talking about Alteplase. So it is the FDA-approved thrombolytic for stroke. It can be used within 4.5 hours from the last known normal. Again, that's why I was harping on that last known normal earlier. The indications for using TPA are an age greater than or equal to 18. And I will say, though, off-label use in teenagers, I've done it myself, know many people who do it, so there is no reason not to rush a teenager in with the same urgency you would somebody over 18. There's still potentially somebody who could be treated. The acute stroke symptoms within 4.5 hours of onset, a CT head that's negative for hemorrhage, and a glucose greater than 50, a blood pressure less than 185 over 110, and that they don't have any other contraindications, which we'll touch on some of those in a minute. Now, recently, things have gotten a bit more complicated. We are able to now treat some other patients, and that's where I come, it's the wake-up strokes. And so there is some studies, evidence out there that we can treat patients if they have an MRI and a certain protocol for MRI that would show them as a candidate, meaning there's enough blood flow and tissue to save, with kind of how we're seeing with those perfusion scans, in order to be able to try to treat within 4.5 hours of being found rather than the last known normal. Now, while this exists, it is not common. There are select institutions that have the ability to do that frequent and that rapid of MRIs. Many hospitals are not doing this. I only mention it because if you are taking to one of those facilities, you may have heard this before and be thinking, what do you mean it can only be within 4.5 hours, last known normal? But not commonly done at this point in time. Hopefully down the line, it will be more frequent and we'll be able to treat more people. But stroke treatment's always evolving, and that's why you should always have the same urgency to get those patients in within 24 hours of symptom onset, and never hesitate to pre-alert and call that stroke alert if it's within 24 hours, because things are constantly changing in what we can do, and sometimes patient stories change too, and they actually are within a window. Next slide. So some of the contraindications to TPA are being on an oral anticoagulant, whether that's one of the direct oral anticoagulants we mentioned earlier, and if they were taken within the last 48 hours. So the timing of that last dose is important to know. Or if they're taking warfarin and have an elevated INR, PT, PTT, we would not be able to treat them. The history of intracranial hemorrhage, any active bleeding anywhere in the body, the history of recent surgeries can have variable effects and certain risks that we have to weigh. It doesn't definitively exclude them, but it's something that has to be considered. Recent stroke in the last 3 months and an intracranial malignancy. There are many more relative contraindications and reasons somebody may not be able to get treated, but these are the basic ones, and I could probably talk for a few hours on all the different contraindications, so we won't get into that today. Next slide. The earlier treatment with TPA, the better the outcome. And that's why everybody's always talking about time and pushing to move as quickly as possible. We have evidence that shows that the sooner you get treated, the more likely you are to improve. So this study showed that the odds ratio for having a favorable outcome at 3 months after being treated with TPA that showed a decrease in as a function of time. So the sooner you got in, the more likely you were to improve. Next slide. And just that reminder again that every minute counts. 1.9 million neurons that you can potentially save with every minute you get that patient to us sooner, or every minute that you're able to save us by gathering a good history and getting those phone numbers and information for us. It's just such a huge impact that you can have on these patients, not only their care right now, but the rest of their lives. Next slide. Okay, now we'll talk about mechanical thrombectomy. So the CT angiogram is required in order to see if somebody is eligible. That's not what we have on the slide here. The CT angiogram was on that imaging slide before. So these pictures are actually of a cerebral angiogram. So this is once they've already gone into the groin with the catheters and gone up to the brain, and those are pictures of the dye being directly injected there. as well as the stent retriever device that we use for thrombectomy. That's what you see in photo D there, is a stent retriever with some blood clot on it. And so the criteria for a thrombectomy is there's a 6-hour time window where if you have an occlusion on a CTA and their last known normal was within that 6-hour time window, they are a candidate for the procedure. And the extended time window, which is newer, and why we have that CT perfusion imaging, is that up to 24 hours after the last known normal and a known occlusion on a CTA, if the perfusion showed brain tissue that we could save, so if that green area had the right proportions to the pink area that already dead tissue, then a patient can be considered, and there's different algorithms to determine whether they're a candidate or not. Just a little bit more about these pictures right here. I can't point to them for you, but I'm going to try to describe it as best I can. If you look at picture A, this is the carotid artery is what you see coming up from the bottom, and the internal carotid. And then if it goes over, you can see it kind of just stops, and there isn't anything on the right side of that picture. Up a little bit more. You can see that. You're right about that, right there. That's where the occlusion is. That blood vessel just blocks off there. And then if you go over to the picture C, in that same spot, you can now see all these blood vessels pass there. On that right side of the screen, it's all full now. So that was that blood clot that they're showing you down below was pulled out of that location and restored all that blood flow to that significant area of the brain. And that's how these procedures provide a huge impact. If you get that blood flow back soon enough and you can save all that brain, it can do even a lot more than TPA sometimes. Next slide. So now we're going to talk a little bit about intracranial hemorrhage. I'm not going to get into all the details here, because again, we don't have that much time. But the symptoms of an intracranial hemorrhage can be the exact same thing as an ischemic stroke. So it's always important to know that until you get that CT scan, you have no idea which one a patient has. Now, a severe headache often makes us think of a hemorrhage more than an ischemic stroke, but I've seen ischemic stroke patients who have really bad headaches too. So it's possible. And also, a very high blood pressure is often associated with hemorrhage more so than ischemic stroke. They both can be elevated, but when somebody's systolic blood pressure is in the 230s, 240s, I'm always expecting a bleed, but doesn't always happen. And the reason I mention this is because I can't tell you how many times I hear patients tell me, I started thinking I was having a stroke, so I took an aspirin. And it's just really important for us to make sure that we're always advising people not to take aspirin for stroke. We don't know if it's a bleed or an ischemic stroke. It is never the best idea to take that in the field before we have that CT scan. And just a little bit about these different types of bleeds here. The first one, right next to our no aspirin sign, is subarachnoid hemorrhage, which is typically associated with a ruptured aneurysm or arterial bleeding. And you can see that that brightness around the brain is what the blood is. And then right next to it is the subdural hematoma. And that's that whole bright area on the left side of the picture. And that's bleeding from a vein that's outside of the brain as well. And then up top in the right corner is the intraparenchymal hemorrhage, which is bleeding into the brain tissue itself. Next slide. Okay, now we're going to touch on the in-hospital stroke care. Next slide. So after we decide if a patient can get one of these treatments, they get closely monitored. Even if they don't get a treatment, there's always concern of a stroke patient worsening and various different complications that they can have. Aspiration is something we commonly deal with because when your face gets weak, you have facial droop, you can also have weakness in the muscles you need for swallowing. And there's many other complications that we won't get into, but we're watching for all those things. And we also want to figure out why it happened, if we can. A third of stroke patients, unfortunately, we don't get an answer to, and we call that a cryptogenic stroke. But there are a lot of tests we can do to try to figure out and try to reduce the risk of it happening. And part of that is modifying risk factors that were all discussed earlier. So there's various different things we could do depending on the risk factors that that patient has. And then also assessing their needs for rehab. Next slide. And lastly, we'll talk a little bit about rehabilitation. Next slide. So there's multiple different types of rehab. Some of our stroke patients are very lucky and fully recover and don't need any rehab, but the vast majority end up getting some level of rehab. There's inpatient rehab, which is the most intensive, and then there's outpatient rehab, as well as those who can qualify for home health, who just have less needs there. And then there's also the thought that the outcomes of stroke, we really assess those at 3 months. So thinking that stroke is something you come into the hospital for and you're able to deal or not deal and leave is really not how it works, unlike a lot of other illnesses. People are dealing with their strokes for a long time. And the good thing is some people can continue to improve over that time. It used to be thought that 3 months was it and that was where you were going to be, but many patients do continue to improve for up to a year if they work hard and with therapy. But it is a long-term issue. So all those minutes at the beginning, all those brain cells we can potentially save really impact somebody for a long time. Next slide. So I'd just like to thank you all for joining us today and listening to this presentation here. We really could not treat our patients without you, and we really appreciate all you guys do every day to get these patients in quickly, and help us to get them the care that they need. And so we will now move on to the question portion. I know that we had a whole lot of questions sent in, which was great, and we tried to address as many of them as we could in the presentation, and then we'll take the rest of them now.
Great. Thank you so much, Dr. Sevilis. The first question is for you. Frank D asks, what are some of the best treatments in the field to help the patient have a good recovery?
So as I mentioned, unfortunately, there really isn't any treatment we can give in the field. The most significant thing you can do is getting that information and getting them to us quickly, because there's no treatments that can be given until that head CT is done. But the significant impact on recovery is getting them to us in that fast time frame and stabilizing them and getting them an airway if they need that.
Thank you. Dr. Behravan, are you on? You ready to take the next question?
Sure, absolutely.
Okay. Derek L. asks, in a relatively normal patient with complaints of dizziness and slurred speech, would it be acceptable to call in a stroke alert or just inform the receiving hospital of the new onsets?
So it is absolutely reasonable, acceptable to call a stroke alert basically within the time frame. So, if they've had the symptoms for a week, they won't be eligible, but it could still be a stroke. So if the question is, whether these are symptoms of a stroke, absolutely, it can be symptoms of a stroke. So it is acceptable, and we want them to be called as a stroke alert so we can have a very quick evaluation and potentially offer treatment if they're a candidate.
Thank you very much. Mary Beth, Dr. Sevilis, Mary Beth asks, are we seeing stroke in younger population?
It's a very good question. We definitely see strokes in younger patients. There's often a question of, are we seeing more strokes in younger patients? And I often flip that around and say, are we seeing them in younger patients, or are we looking for them now? Stroke was always thought of as a disease of older people. But I've treated somebody with TPA down to the age of 15. So, teenagers can have strokes, 20-year-olds can have strokes. We need to be looking for strokes at any age. If they have the symptoms, the concern should be the same.
Thank you very much. Dr. Behravan, what stroke symptoms are commonly missed in the field?
Good question. So there are several studies looking at these exact same question. So typically, and again, these may not be common presentations of a stroke, but as Dr. Sevilis mentioned, they do happen. So headache, nausea, vomiting, dizziness, even confusion, altered mental status. These are the common symptoms that can be missed. It's not like they're missed as, not detected, but they're missed as potential symptoms of a stroke. Now, there are also some symptoms that could be missed, not detected at the scene. For example, if there is a, small visual field defect, if there is a minor degree of neglect, these are the things that even in the hospital ER setting could be difficult to examine, could be difficult to assess. So they could be missed as not detected. But as I mentioned, there are some general symptoms that at first may not jump in as a potential stroke symptom, but it could turn out to be a stroke. Again, headache, confusion, nausea, vomiting, and dizziness are the main ones.
Dr. Behravan, I'm going to put you on the spot for just a second. Trish just asked the question, can you please address dizziness only as it translates to the incidence of stroke diagnosis and perhaps your experience with stroke alerting for this alone symptom to kind of further on what you were talking about?
Because sometimes we may get frustrated if stroke is called and it dizziness for a patient with, let's say, systolic blood pressure of 50. But at least I personally prefer that dizziness cases are called because, again, first of all, the evaluation in the field could be difficult for, I'm just going to come up later, for other potential symptoms, signs and symptoms that could accompany it. For example, certain nystagmus, kinds of nystagmus, coordination difficulty, and we may not necessarily be able to evaluate gait, and there could be some non-specific symptoms, nausea, vomiting, things like that. So dizziness, if it's acute onset, and that's very important, acute onset dizziness should be called, even if patients kind of describe it as lightheadedness. But more importantly, if someone states that all of a sudden everything started spinning around me and they're very vertiginous, they have some other symptoms such as coordination difficulty, double vision, significant nausea, vomiting, it should be called because it definitely needs to be evaluated for a stroke. It doesn't necessarily mean that it's going to turn out to be a stroke, and their evaluation could be a little different in the ER, but it's better to very quickly evaluate them for stroke evaluation by a neurologist.
Thank you very much. The next question for Dr. Sevilis is from Michael D. How can you assess, and I am sorry, I cannot pronounce, nystagmus to determine if it's vertigo or CNS insult?
So nystagmus is complicated. There's a lot of different things that it can mean, and the main things that are probably the simplest, let's say the simplest way to think of your concern for CNS insult is if the nystagmus is vertical. Horizontal nystagmus can often be vertigo and coming from the ear and other issues, but vertical nystagmus is a big red flag that this is coming from the brain, as well as nystagmus that changes directions. So those are two of the easiest ways to kind of look for it. But again, in the field, if you're seeing nystagmus and hearing dizziness, getting them in urgently and letting that evaluation occur in the ED is the most important. I wouldn't say if the nystagmus is not one of those two things that means it's not a stroke, because that's not the case. It certainly can be for other things too. Those are just some pretty telltale signs for a CNS process.
Thank you very much. Dr. Behravan, in a wilderness setting, when transport times can be hours because of lack of access or difficulty landing a helicopter, what can we do to take our patient to an ambulance? Is it okay to walk a patient who has the ability to walk?
All right, interesting question. So the two important things here, one is the safety, and then the other one is time. So as we discussed earlier, it is very, very important to have the evaluation as quick as possible. So get the patient to the hospital as quick as possible. And we'll see it in other elements of the stroke guidelines that, we should not really waste time getting labs or, getting lines even at the scene. And we should get the patient to the ER as fast as possible. So that's one element. The other element is, well, of course, safety. So if a patient is ambulating, for example, has arm weakness, and you think that them ambulating themselves would make it, it is safe and it would make it much faster getting to the hospital, sure. It would be reasonable to have them walk to the ambulance, get them to the hospital as quick as possible, again, as long as it is safe.
Thank you very much. All right, Dr. Sevilis. Heather V asked, do you recommend a specific LVO recognition tool for EMS?
So there isn't, there's a few different tools out there. Isn't one that I'd necessarily have a preference for. There's the RACE tool, the Cincinnati Pre-Hospital Stroke Severity Scale, the Los Angeles Motor Scale. It's really challenging to recognize a LVO in the field all the time. So there's no one tool that is going to make it so that you don't miss LVOs. And there's no one tool that's going to predict it 100% of the time that you're that is actually going to be an LVO. I think it's something that's been somewhat of a challenge. I know there's lots of triage processes in which certain hospital systems try to take LVOs to the centers that can do the interventions as opposed to the nearest stroke center. And I think for a lot of our EMS, actually being able to recognize an LVO is less important because if they don't have a comprehensive, they're not picking between a comprehensive and a primary stroke center. They're just going to take them to whatever's closest. But I think any of those three tools I mentioned can do the job as best as we can do the job right now, if that makes sense.
Great. Thank you. And Dr. Behravan, can you share ways to identify hemorrhagic strokes?
So at the field, in the scene, I actually recommend that we don't try to differentiate between hemorrhagic stroke and ischemic stroke. So the symptoms, could be a little different, but as Dr. Sevilis, stated earlier, ischemic strokes can have the symptoms that we more commonly seen with hemorrhagic stroke, such as, extremely high blood pressure, terrible headache, very severe headache, severe nausea, vomiting, very rapid, alteration in consciousness. These are the symptoms that we see more with hemorrhagic strokes, but it doesn't mean that it is definitely hemorrhagic strokes. We have all seen similar symptoms in ischemic strokes, so it's not reliable. The other thing is, yes, for example, the question, 12 lead EKG, there are EKG changes that we can see with stroke, but it's not used as a tool. For example, T inversion is seen with hemorrhagic strokes, but it's not going to differentiate between ischemic stroke and hemorrhagic stroke. And the other thing Dr. Sevilis mentioned earlier, we don't want to diagnose it at the scene without having a CAT scan, and for example, giving aspirin or blood thinners that can potentially worsen a hemorrhagic stroke. So there are symptoms that are more consistent with either of the type of the stroke, but we can't really differentiate it. The CAT scan would be the tool to differentiate them.
Wonderful. Okay, and then I do have a lot of anticoagulant contraindication questions that we'll get to right after our last two questions here. How can we better identify posterior strokes in our hospitals for Dr. Sevilis?
So that was, as I had mentioned earlier, I really like BFAST for that reason, because when you're thinking of anything that has to do with balance, I can't walk, I'm unsteady, I'm dizzy, any of those terms should be a trigger. Anything with vision. I know there's often some hesitancy when somebody's saying, I can't see on the left with my left eye, because they assume, it's got to be something ocular, it's the left eye, I'm not going to worry about that, but it turns out to be the left field. I mean, we would always rather be called than not called if there is any vision issue, double vision, loss of vision. I mean, those things, they're hard to tease out sometimes, and we don't want people taking the time to tease them out. We want you to call us right away and let somebody know so that we can figure that out and get them treated in a timely manner if it's needed. So I think it's really just thinking about those other words and not just my face is weak, my arm is weak, I can't talk, or I'm numb. Those are the main things that people think of, but for remembering the dizzy imbalance and any vision changes whatsoever.
Great. And how are field labs acceptable to most hospitals when considering a stroke diagnosis, Dr. Sevilis?
So the getting IVs is huge. If you can get an IV in the field and get that so that that's already there when we get to the hospital. And a lot of hospitals, if do take the blood from there can say, I often hear it's hemolyzed or it didn't work and they had to redraw labs. But if you're able to get it and potentially give us a leg up on if they are somebody on anticoagulation and get the INR back sooner, then I don't see any issue with that. That's really set up individually with hospitals, though. I can't say necessarily proportion of most hospitals per se. I've seen many hospitals who do get labs from the field, but that's usually a kind of agreement and plan between the hospital and their local EMS team.
Great, thank you so much. And so these are, we've had a lot of questions about anticoagulants. So these are for both of you if you guys want to answer and share. A daily aspirin, would you consider that a contraindication?
No. You can treat with aspirin and Plavix. Neither one of those is considered an anticoagulant. They're antiplatelets. It's a quick overview. There's a category of antithrombotics, which aspirin and Plavix are antiplatelets within that category. And then the anticoagulants, which is what we're concerned about, are the warfarin or Coumadin, which are the same thing, Pradaxa, Xarelto, Lovenox, Eliquis. Those are all the anticoagulants that we worry about.
Okay, so yes, Coumadin was actually asked by Rachel. What about turmeric and fish oil? What are your stances on that?
They wouldn't be a reason that we can't treat.
Okay, great. Are there any other anticoagulants that you could think of, or any other things that the EMS should be asking in the field that would be a contraindication? Medication.
Medication-wise, I mean, those are the main things to be asking about is the anticoagulants.
Great. Does anyone else in the audience have any other questions? You can feel free to ask them in the Q&A. We've had a lot. Is it possible to count this as a CME hour? We do not have CME. However, we can provide a certificate of attendance for this hour. So we are hopefully working on getting actual verification of CMEs. So any other questions? Yes, it is recorded for Lisa. We will be sharing it. Yes, we should have this out in the next day or two for you to share, and we will send it to anyone who attended to the webinar. So feel free to share it with your friends as well. Well, I think Tasha said this has been fantastic. Thank you again, Dr. Sevilis and Dr. Behravan. You guys, as always, have done a wonderful job, and we appreciate you taking your time to help educate and share your vast amount of knowledge.
We appreciate everybody taking the time to join us and help us all work together to improve stroke care.
I appreciate it. Without you guys, the good care is impossible.